technical difficulties this morning, but thank you for your patience. And we are back again with another installment of our Princess Margaret Hospital CME presentations. And joining us this morning is Dr. Beverton Moxey. Dr. Beverton Moxey is no stranger to this crowd. Dr. Beverton Moxey is a gastroenterologist. He is a consultant engaged at the Princess Margaret Hospital and Doctors Hospital. And I will let Dr. Moxey introduce himself a little bit more and tell you about his training and his interests. And then he will continue with the presentation. And please remember, you can post your comments in the chat. So welcome, Dr. Moxey. And when you start your presentation, you could let me know when you want me to move on with the slides. Welcome, Dr. Moxey.
All right. Good morning, everyone. Good morning, colleagues. Thank you very much, Dr. Iblack.
Okay. Dr. Moxey, you need to unmute. Have you unmuted your mic?
I have. You're not hearing me. Okay.
Okay, we hear you now. Go ahead.
Okay. Yes. Good morning. Good morning, Dr. Iblack, and good morning, our colleagues. Thank you very much for that introduction. So as Dr. Black indicated, I am a gastroenterologist. I started my training at the University of at the University of Virginia, internal medicine. And then I completed gastroenterology fellowship at Cleveland Clinic. I've been practicing now. I would have started practice in Nassau in the Bahamas in 2005. And I've been with Princess Margaret Hospital since that time. My clinical interests enjoy inflammatory bowel disease, as well as colon and endoscopy as some of my interests within the field of gastroenterology. And so it is my pleasure this morning to present this topic to my colleagues, and I hope that it's something that we'll all walk away with being better off at the conclusion. And so I chose a very catchy, I guess, title: "All Fat is Not Equal: The Pros and Pitfalls of Fatty Liver Disease." And we can advance the slide, please, Dr. Black. And so the objectives for this morning talk are, one, to debunk the myths related to fatty liver disease. So a lot of times when you speak to people about fatty liver disease, the first inclination is that, oh, it must be because of significant alcohol use. And so I thought that this topic was fitting, and one that we've probably not seen on the landscape of grand round presentations for gastroenterology, because there's so much more to fatty liver than that meets the eye. And so I wanted to outline some of the common differential diagnoses and also discuss the pathophys and diagnosis and management of fatty liver conditions that may not be as common, but that we certainly do not want to miss. Next slide. And so we're going to start out with non-alcoholic fatty liver disease, which is a common entity, more common than we think. And so I'm sure that oftentimes a lot of us would have ordered an ultrasound or a CAT scan on a patient, and we would have gotten back results that would have indicated to us that there's fat on the liver. And so sometimes, what do you do with that? And this is analogous to people getting, us when we order scans and we see cysts. You have cysts on the liver, cysts in the pancreas, cysts in the kidney. Is there significance to those items? And so I wanted to bring a heightened awareness to what and how we should be thinking when we get that report that says fatty liver. And so chronic liver disease represents a major global health problem, and non-alcoholic fatty liver disease is one of the most common liver diseases in developed countries. Obesity, diabetes, insulin resistance, a sedentary lifestyle, and Western diet are key factors contributing to non-alcoholic fatty liver disease. And as you would note, a lot of the chronic non-communicable diseases that are mentioned there are things that we see that are very pervasive and are prevalent in our society. Next slide. So what's the definition of NAFLD? And so NAFLD is defined as having evidence of hepatic steatosis, and that's either by imaging or histology, and lack of secondary causes of hepatic fat accumulation. And that could be resulting from significant alcohol consumption. And when we look at the guidelines that are presented by the all of the major liver societies and gastroenterology societies, what is considered significant alcohol consumption is greater than 21 standard drinks on average per week in men and greater than 14 standard average drinks in women. Two, if someone, there's no reason that a patient has taken any steatogenic medication. So there's some medications that are prone to cause fatty liver. Valproic acid is one culprit of such a medication. And thirdly, if there are no other chronic liver diseases, such as a patient having fatty liver from, or having a chronic disease such as a hemochromatosis or Wilson's disease, autoimmune hepatitis. Next slide, please. So when we look at what's the impact of NAFLD on the world population, and so it is accepted and has certainly been studied that NAFLD actually accounts for 25% of the world's population. So 25% of people within our population actually have non-alcoholic fatty liver disease. And it's the second most common cause of end-stage liver disease and the need for liver transplantation. I will repeat that. Non-alcoholic fatty liver disease is the second most common cause of end-stage liver disease and the need for liver transplantation. And it is predicted that it will become the most common indication for liver transplantation in the next decade. Currently, hepatitis C is, and with the advent of antivirals that have been successful in the treatment of hepatitis C, it is expected that non-alcoholic fatty liver disease will take over that position. And is also now considered the third most common cause of hepatocellular carcinoma. Next slide. So what are some of the risk factors? So when we look, I want to focus your attention to the column in the left. And so that describes the characteristics of certain persons or a patient population. So in someone who is morbidly obese, greater than 90% of those persons would have the presence of fatty liver disease. And a diabetic, we see NAFLD in 60 to 70% of diabetics. Persons with metabolic syndrome, 53%. Persons that have a dyslipidemia, 50%. Male gender is 2 times more likely to have NAFLD compared to females. And what we found is that persons of Hispanic ethnicity are more prone, and we see it 45 to 50% more in that population compared to others. Next slide. So NAFLD can be categorized into non-alcoholic fatty liver or non-alcoholic steatohepatitis, abbreviated as NASH. And the difference between the two really drills down to whether or not there's injury at the hepatocellular level. to the actual hepatocytes of the liver. And so with NAFLD, you have the presence of steatosis, which is the fat, but you have no evidence of injury to the hepatocyte. In NASH, you have the presence of the fat and inflammation, and there's also injury, and that injury is expressed in the form of ballooning of the hepatocytes with or without signs of fibrosis. Next slide. And so when we look at the spectrum of non-alcoholic fatty liver disease, this is just a schematic to kind of show you what happens. And I would have talked about some of this just recently with NAFLD, with NASH, and then it progresses on to cirrhosis. And cirrhosis is a risk factor for the hepatocellular carcinoma. And when we look at some of the concurrent diseases that can actually contribute, we see at the top acute fatty liver disease. We have drug-induced fatty liver disease, and we have HCV, which is hepatitis C associated fatty liver disease. And then others are the hemochromatosis, the autoimmune hepatitis, persons with celiac disease, Wilson's, endocrinopathies, starvation. Parenteral nutrition is also a cause of fatty liver and inborn errors of metabolism. Next slide. So what is the natural history? And so when we look at non-alcoholic fatty liver disease, it is a slowly progressive disease, and it affects both adults and children. And so the rate of progression corresponds to one fibrosis stage every 14 years in NAFLD and every 7 years in NASH. So if you have a patient that's been diagnosed or that has been shown to have evidence of non-alcoholic fatty liver disease on imaging, and you do absolutely nothing to treat that, within 14 years, they're going to be moving toward the stage of developing fibrosis. And if they've already progressed on to having NASH, then within 7 years, they're going to progress onto stage 1 fibrosis. And so this rate of progression is also further doubled in a patient that may have a coexisting diagnosis of hypertension. And so the progression of fibrosis is more rapid in about 20% of cases. So generally speaking, this is the rate of progression that you can expect. But we know that things are not always textbook style, and it's not always research, and there's always some anomalies. So there's 20% of those cases that are going to progress even more quicker. Next slide, please. So this is
Dr. Moxey, my apologies. Are you seeing the whole slide?
I am.
Okay.
I am seeing the whole slide. Thank you. So when we look at, this is a schematic here that shows us, again, what is the progression of NAFLD over that 8 to 13 year period. So you would see at the very top left-hand corner, steatosis, which is the beginning stages where you have the fatty liver. 12 to 40% of those people are going to be progressing on to NASH. Okay, and then you progress on to fibrosis, and then you go from fibrosis to cirrhosis. And once you have cirrhosis, there's a risk of developing hepatocellular carcinoma. And so in our cirrhotic patients, no matter what that cause is from, if that cause is, as a result of alcoholic liver disease, if it's a cause of non-alcoholic fatty liver disease, autoimmune hepatitis, or any of the viral hepatitis. Once you have a patient that has cirrhosis, a part of your screening, a part of your surveillance is always surveilling them and screening them for hepatocellular carcinoma, because their risk of developing that goes up exponentially. And so we do that either by yearly ultrasounds or by alpha-fetoproteins or by a combination of both. Next slide, please. So when we look at, this is another schematic that just kind of explains, some of those big risk factors in terms of the pathogenesis. And so when you look at high calorie intake, so you see it all kind of correlates back to diet and lifestyle. High calorie intake, excess intake of saturated fats, high fructose, which is again sugar, sedentary behavior. All of those lead to obesity, which is a great risk factor for NAFLD. Next slide, please. And so wanted to show this, I thought this was a cool diagram to kind of just show some of the things that's going on in the background. So you have, just to kind of orient you, you look to the left, poor nutrition. So you have poor nutrition, which is going to be that high fat, high carbohydrate, high sugar diet coming into the liver. So that's going to now cause you to have a lot of free fatty acids, cause you to develop a lot of the visceral fat and increase adipose tissue. And so in having that, in the background now, you are then causing this fat to accumulate into the liver. That fat accumulating in the liver over time can then become, develop inflammation from oxidative stress, insulin resistance, and it just points to the far right where chronic inflammation over a period of time leads to scarring, which is fibrosis, and that fibrosis can lead to cirrhosis, which ultimately can lead to hepatocellular carcinoma. And so that's the progression, a schematic just basically showing that the progression that we would have discussed. Next slide, please. So what are some of the common related metabolic disorders? So we, in our practice, as family practitioners, as internal medicine, physicians, as generalists, would see a lot of patients that would fit these criteria of metabolic syndrome and insulin resistance. And so to have a definition of metabolic syndrome to be categorized as that, you need three of the following: either impaired fasting glucose or type 2 diabetes, hypertriglyceridemia, a low HDL level, increased waist circumference, as well as high blood pressure. So just three of those components, and you meet the definition, the criteria for metabolic syndrome. And I'm sure we can all think of, when we think of our patient population, we know that hypertension and diabetes and obesity are some of the more prevalent chronic non-communicable diseases, in our country right now. And so we would imagine, when we think of that landscape of patients, how many persons we would probably have that are afflicted with NAFLD. Next slide, please. And so what's the, in terms of the diagnosis? And so when you're trying to determine what is the underlying cause, you've done a scan. Incidentally, you've been told that there's steatosis or there's fat in the liver. And so now what next? What do you do next? And so your initial evaluation, you want to drill down to find out, is this, fatty liver, is it a result of non-alcoholic, or is it a result of some other cause? And so you want to ask questions about alcohol intake. You want to ask questions about past medical history and even personal and family history of diabetes, hypertension, cardiovascular disease. You want to do your proper triage where you are checking weight, waist circumference. You want to do screening for hepatitis B and hepatitis C virus infections. You want to check a medication history. You want to do liver enzymes and fasting blood sugar and an A1C to get an idea on if persons meet the criteria for the diagnosis of diabetes or impaired fasting glucose. You want to check a CBC, the complete blood count. And specifically in that, we're looking to see the platelet count, which we know that in persons who are having issues with chronic liver disease, they tend to have low platelets. You want to check the lipid panel to look at the total as well as the HDL and triglyceride levels. And of course, if the mode by which you did the tests if you don't have imaging, you would want to check an ultrasonography just to get an idea for what's happening. Extended evaluation beyond that, when you want to drill deeper, you would look for things like check your iron, ferritin, transferrin saturations, looking for evidence of hemochromatosis. You may also check the smooth muscle antibodies, looking for autoimmune hepatitis. And we would not have really in our population, because these, the Wilson's and the alpha-1 antitrypsin disease, they tend to affect, are not prevalent or not common, period, and certainly are not common in our population. Next slide. So diagnosis. And so the question then becomes, how do we now kind of clinch this diagnosis as to what's actually causing, if you do a scan and you want to kind of see if somebody has this, fibrosis, or if they're progressing on. So typically when I have a patient that has non-alcoholic fatty liver disease, one of the telltale signs of really, if this person has steatohepatitis, is really checking the liver function test. If the transaminases are elevated, that clues you in that the liver is irritated, it's inflamed, and this patient is likely in a NASH presentation. In terms of determining fibrosis, now you're looking at, how do we determine that? Do we do a liver biopsy, or is there another modality? Well, there have been other modalities that have been researched, that have been kind of tested, that are least invasive compared to liver biopsies. And so they have transient elastography, like the fibroscans, or you can do the magnetic resonance elastography. And these are clinically useful tools that are non-invasive, that are useful in terms of identifying advanced fibrosis in patients. And so to give you an example of how elastography works, it is essentially a probe that you put onto the liver, and you're sending vibrations. And it's a measurement of how quickly those vibrations get across that liver, and to put it in simple terms. And so in someone that has a liver that's more fibrotic, that's more stiff, it's going to pass through quicker. In a liver that's more normal, that does not have evidence of fibrosis, the time travel is actually less. And so that's the technology, or that is, behind doing those non-invasive measurements of elastography. Next slide, please. And we don't have it available here, unfortunately. There's also, we can skip this, actually. Next slide. So when should you do a liver biopsy? Well, a liver biopsy can be done in instances where you don't have the ability to do non-invasive testing. And so you should consider it in somebody who you suspect has an increased risk of having steatohepatitis or advanced fibrosis. And you would have either imaging criteria that would be suggestive, or you're going to see that elevation in your liver enzymes and other serum markers that would be suggestive of you, somebody having steatohepatitis. Usually the presence of metabolic syndrome. Also, and even when persons would have done a non-invasive testing, there's still recommendations in terms of proceeding with liver biopsy. And so this is something that we have available at both institutions in terms of being able to get an idea for tissue sample. And so certainly, it is a modality that I would recommend if we are faced with having a patient that we suspect has this condition, because it's critical in how you survey and how you manage, because these patients, there's an opportunity to actually, and we'll talk about it later, somebody who has steatohepatitis or fibrosis, there is an opportunity to provide treatment that can actually reverse. And even at the fibrosis stage, you can reverse. And so you want to prevent that patient from progressing on to cirrhosis, where the only thing that's available to them at that point would be liver transplantation. Next slide. And so once we do a liver biopsy and we send that sample on to our pathologist, so they're going to be categorizing and looking for certain things. And so for non-alcoholic fatty liver, they're going to just see steatosis alone, plus one of the following, either lobular or portal inflammation, or ballooning. For NASH, they're going to see steatosis, they're going to see inflammation and ballooning. And then, of course, they would have the criteria that they would be looking at for like the bridging fibrosis and the necrosis, and criteria to determine if somebody has progressed to a more advanced stage for fibrosis or cirrhosis. Next slide. So I think we would have talked about this already, so we can skip this in the interest of time. And again, just, I like pictures. Pictures say 1,000 words. And so when we look at a healthy liver to the left, we have an obese patient, which is increased adipose tissue, increased free fatty acids, triglycerides, which lead to this top right-hand corner where we say isolated steatosis. So that's still reversible. You have the increased presence of fat in the liver, and then that progresses down to NASH, and you see the arrow back and forth to even at NASH, which is the non-alcoholic steatohepatitis stage. It's still reversible. But once you progress on to the cirrhosis stage, now you've reached the point of no return, and that's at the bottom of the schematic. And so then now we move into the mode, shift into the mode of now having to screen these patients for the hepatocellular carcinoma. We also do endoscopy screening on them because they're at risk for developing esophageal varices. We do the ultrasonography, monitoring for some of the signs of advanced liver disease, such as the ascites and management. And so this is what we want to avoid. And so, because we want to try to arrest this at the point of NASH and where it's still reversible. Next slide. So let's talk about some of the management. I think we've kind of gone through what is NAFLD, how it presents. And so there's pharmacologic therapy, as well as therapy is focused a lot on lifestyle management and diet. Next slide, please. So some of the pharmacotherapy, and we talked about where you can arrest it. Treatment should be indicated in persons who have progressive NASH. Treatment would reduce NASH and related mortality and progression to cirrhosis, as we talked about. And so some of the things that we want to look for is to make sure that we're choosing the right treatment for the right patient. So safety and tolerability. Next slide, please. And so one of the things that I wanted to point out is that even though we have medications that we're using for NASH, there are no drugs that are approved for NASH. There's no specific therapy. And the treatments that we are giving patients for NASH are off-label. Next slide. So let's start with diet and lifestyle challenges. So we see that most of the reasons why persons develop NAFLD is because a lot of it is because of obesity. And so I think if we can target that at the outset, that goes a long way. And so you want to try to have patients make an adjustment to diet and lifestyle changes. And I think it's more than us just having a conversation with that patient. It may require them to have further help, referral to a nutritionist or a dietitian to really help them to get on the right path. In terms, a lot of people don't know how to eat. I think it also may require maybe a suggestion to say, consider getting a trainer, getting somebody to actually help them, to keep them accountable with exercise and making sure that they are doing all that needs to be done to lose that weight. Modest weight loss reduces liver fat and improves the hepatic insulin resistance, and it can result in NASH regression. And what we have seen, what studies have shown, is that weight loss of greater than or equal to 7% is associated with histologic improvement. And so you can see reversal in those changes in the liver with just only 7% loss of weight. Next slide, please. So some of the things, I thought that this was a great slide here. Like when we look at in the middle, we put the comprehensive lifestyle approach. So you want to, top right, let's go around in a circle. Fructose intake, avoid those sugary drinks, reduce your alcohol consumption. Physical activity is important. Doing it several times a week, resistance training to promote musculoskeletal fitness and improve metabolic factors. When you look at macronutrient compositions, you want to have low to moderate fat in your diet. You want to, have low carb, ketogenic diets, high protein. Coffee doesn't have any bearing, which is great. So we can have our coffee. Energy, in terms of looking at the restriction calorie, you want to restrict your calories, reduce them by 500 to 1,000 per day. Because you want to promote at least that 7% weight loss. That's your target. And you want to try to be able to do something that's sustainable. A lot of times we go on these quick fixed diets, but they're not sustainable. And so you have to have something that you can sustain in terms of a long-term maintenance approach. Next slide. So I think we would have kind of talked about this. It just kind of goes over having that weight loss. We can go to the next slide. So let's talk about some of the pharmacotherapy, insulin sensitizers. So the only medication really that's been shown to show some benefit is the pioglitazone, which improves liver histology in patients with and without type 2 diabetes that have biopsy-proven NASH. And so, it is recommended that it's used in those patients. And so you have to weigh the risks and the benefits. We know that there have been some issues with these glitazones and, in patients especially that have underlying cardiovascular disease. But this is a medical therapy. And so certainly if we put somebody on it, we need to make sure that we're monitoring them very closely. And one of the things that I want to highlight here is that we really shouldn't be starting this drug unless we actually have biopsy-proven NASH. That's what's recommended because of the risks that are associated. Next slide. Vitamin E, I use this very commonly in patients. Administered at a daily dose of 800 units a day improves liver histology in non-diabetic patients with biopsy-proven NASH. And truth be told, I'll tell you, I even use it in persons, I use it from the outset. When somebody has fatty liver disease, I start them on vitamin E, and I may start them on anywhere between 400 to 800. And this is just having the presence of steatosis on the liver. And so this has been shown as an antioxidant to have some benefit. And so, I think that this is something that we can easily, adopt and take into our practice in terms of starting. And so I would certainly recommend that this is an option for us as clinicians. Next slide. And then, of course, for those persons who are struggling with weight loss and that really have a challenge, we may have to consider weight loss surgery, bariatric surgery, for those to get that BMI down and to be able to achieve the goal to lead to the reversal of the NASH from development into cirrhosis. And so, of course, even after doing these surgeries, these weight loss surgeries, it still requires the patient to maintain. And so it does require a lifestyle approach and modification. Next slide. I'll skip this in the interest of time. We can go to the next slide. And just some miscellaneous guidance. So that's from a lot of the societies. Patients with NASH cirrhosis should be screened for varices. We would have talked about that. They should also be screened for hepatocellular carcinoma. These are practice guidelines that we follow. And there's no evidence to support screening for hepatocellular carcinoma in patients who do not have cirrhosis. And let's go to the next slide. So let's talk about some, I think I have maybe about 3 slides on pediatric non-alcoholic fatty liver disease for some of my pediatric and family medicine colleagues that practice with peds. So it is a concern. Same complications. There is a potential for severe liver-related complications in life. And so we've seen, there's evidence of persons as young as 8 years old developing NASH-related disease and progressing on to cirrhosis. Next slide. And so childhood obesity is something that, we as clinicians should, really be focused on and really address, in patients. And so, of course, once you have that suspicion, you want to, of course, rule out all of the other comorbid, chronic liver diseases. You want to check for the autoimmune disorders. And so just to make sure that there's, nothing else concomitant that's actually happening. But there's no, it's really an index of suspicion. And so it's certainly something that I think as we see our patients, our pediatric patients, and we are, measuring their growth and measuring their weight and BMI, it is certainly, as clinicians, it should remain at the forefront of our minds and something that we should be actively having discussions with the parents in terms of how do we manage this, because all of the complications that can develop as a result of obesity and child being overweight. Next slide, please. When should you biopsy? So again, this could be in the child, if you happen to have a child that's having, significantly deranged LFTs. There's, certainly ultrasound or imaging that suggests that there's a problem. You would want to consider having this child biopsied for confirmation. And then, because at that juncture, you would need to start therapy. And as in adult patients, you don't want to start any potential therapy that can be, that comes with side effects without having an established diagnosis. And, and so we should treat this in the same manner that we wouldn't just arbitrarily give someone chemotherapy and not have an established diagnosis of what their pathology is. Next slide. And just a schematic that kind of goes over some of those things that we've all talked about already. I wanted to give, pediatric, their slide, they're not little adults, they're children. And so, but it's the same thing you see, it's the diet, it's the hyperinsulinemia, it's the increased lipids, the increased transaminases, and all of that contributes to the development of the NASH and the non-alcoholic fatty liver disease. Next slide. And so, again, when we talk about for children, want to point out that metformin does not provide any benefit. Again, you can look at giving a child vitamin E supplementation, and you may want to try a lower dose in terms of treating that child. But of course, as I would have indicated, that none of these are all off-label uses, but they have been shown to have benefit, just in the event, in the way that the medications work for pharmacotherapy. Next slide, please. All right, so let's switch to something a little bit more exciting for some of our gynae colleagues. And so fatty liver, I had a case actually that I co-managed recently with one of the obstetricians. I think it was earlier this year, where we had a patient that came in, and all of the signs and symptoms certainly pointed towards acute fatty liver of pregnancy. And so the obstetrician, once we kind of all put our heads together with this, a quick decision had to be made, which we'll talk about, later, and it was made. And so, but this is one of those things where it's rare. It typically occurs in the third trimester of pregnancy. It cannot be predicted or prevented. It's characterized by microvesicular fatty infiltration of hepatocytes without any inflammation or necrosis. Of course, oftentimes this decision is being made in the absence of actually having a liver biopsy, because that's a very tricky and risky thing that nobody wants to put a patient through that's in the third trimester of pregnancy. And so rarely liver biopsies are done, but decisions are made on this clinical presentation based on other parameters. And so what makes acute fatty liver of pregnancy very dangerous is the fat accumulation along with the ammonia production by hepatocytes. It leads to eventual coagulopathy, hypoglycemia, and it could progress to fulminant hepatic failure. And so it really requires, one, to have an index of suspicion. So it should be one of those things that, even though it's rare, it should always be in the back of your mind. And, I was always taught, and when I teach on service with the residents, I always say, if you never think of the diagnosis, you'll never make the diagnosis. And I think that, and the teaching style that I like to always put out there is that whenever I'm rounding and, somebody gives a presentation and they're like, this person is coming in and they have, increased swelling in their legs, they're short of breath, their JBP is up, they have heart failure. And I say, okay, great. That's what else can cause this picture. We know what the diagnosis is. Now I want you to tell me what else can present like this. And so, and so to me, differential diagnosis is important, and that helps you to always keep things fresh and keep things at the front of your mind. And that's how I was taught medicine. And so for this, while it's rare, it's one of those things that you always want to keep in the back of your head when you see things happening. And there's a spectrum as it relates to, acute fatty liver that goes from the gamut of the preeclampsia, eclampsia, HELP, and going on to this acute fatty liver of pregnancy. Let's go to the next slide, please. So this is just some information. The exact cause is not known. There's a lot of theories talking about mitochondrial dysfunction and the oxidation of fatty acids. And although the risk of acute fatty liver in subsequent pregnancies is not known, it can occur again. So, there's been some, there's an association with there being a deficiency of L-chat, which is a long chain hydroxy-CoA dehydrogenase, which is an enzyme that's used to break down long-chain fatty acids. And so, it can recur. And so, we want to always, keep that, at the forefront. Next slide. And so why is acute fatty liver pregnancy a concern? Because it's both mother and fetus are at a high risk for mortality, morbidity, and mortality if it's not treated. And some of the things that can progress could be a fulminant hepatic failure, hemorrhage, kidney failure, so a multi-organ system failure, severe infection, and these things can be life-threatening for the mother and fetus. And so early diagnosis and treatment helps to improve outcomes. Next slide. So what are some of the symptoms? So again, we said this begins late. It's in the third trimester. The patient's having nausea and vomiting, abdominal pain, right upper quadrant, just malaise, headache, tiredness, confusion, jaundice. So those things would be some clues for us to start looking into whether or not this is in the realm of possibility. Next slide. And what we have seen in the past, maternal and perinatal mortality was reported to be as high as 75% and 85% in the past. However, but due to now the ability and having a greater sense of recognition of the condition, prompt diagnosis and treatment, we've seen these numbers decrease dramatically to 18 and 23%. Respectively. Next slide. And the best, the best treatment is immediate delivery, and so it's supportive care and delivery of the fetus. And so, what are some of the risk factors? We talked a little bit about it. The deficiency of the LCHAD. This seems to predispose women. We see it more commonly in prima gravidas. Persons that have preeclampsia, mothers that are carrying male fetuses, and in persons who have multiple gestations. Next slide. All right, so moving on, I saved the one that's thought of that's usually at the forefront, alcoholic liver disease, for the last, because I really wanted to stress the importance of non-alcoholic fatty liver disease and how pervasive it could be within our patient population. And so, of course, early manifestation of alcoholic liver disease is the presence of fatty liver, which is the steatosis. And this spectrum can range again from steatosis to alcoholic steatohepatitis to fibrosis and cirrhosis. And so steatosis, just as in NAFLD, is the earliest stage. All right, next slide, please. And so again, characterized by the buildup of fat in the liver cells, and steatohepatitis is defined by the presence of fatty liver, inflammatory infiltrate, and hepatocellular damage. So we may see the hepatocellular damage and the inflammatory nature being manifested with elevated transaminases. And we need to also keep in the forefront that these patients can, just as in NAFLD, progress onto fibrosis and cirrhosis. Next slide. And so this just describes, this slide, what our pathologists would be looking at. Looking at a slide in a patient that may have a liver biopsy, you're going to see more pericentral and perisinusoidal areas of fibrosis and collagen deposits, as well as bridging fibrosis in persons that would have alcoholic liver disease and fibrosis and cirrhosis as a result of that. And next slide. And so we want to talk about, one of the things that I wanted to mention is like the two-hit hypothesis, which, postulates that first you have the fatty liver first, and then this fatty liver is then susceptible to secondary insults that further drive, that's going on in the background, that further drives the progression of the patient moving from the steatosis onto the fibrosis onto cirrhosis. Next slide. And in terms of alcoholic fatty liver disease, Within the liver, there are two main pathways of alcohol metabolism. So it's either alcohol dehydrogenase or the cytochrome P450-2EI. The alcohol dehydrogenase is the hepatocytosolic enzyme, and that converts the alcohol to acetaldehyde, subsequently, which is metabolized to acetate via the mitochondrial enzyme. That I can't seem to get that pronunciation right this morning, a tongue twister.
Acetaldehyde dehydrogenase.
Thank you, Dr. Black. Next slide for me, please. And that's it. So I am available for questions. Hopefully, I think for me, the biggest, what I really wanted to present on is really non-alcoholic fatty liver, which I think it's something that we see a lot and we may not know what to do with it. But as in my discussion with Dr. Black, I said I want to keep it interesting and throw some other stuff in there. So I included the acute fatty liver of pregnancy, and of course, just briefly mention alcoholic liver disease, which we all commonly think of. But I hope that at the end of this presentation, when we see fatty liver on a report that we would have received incidentally, that it really causes us now to pause and to figure out what is our next move and how we should handle and manage this patient. And this is really somebody that you should be managing along the way, just as you manage a hypertensive, a diabetic, an asthmatic, just to make sure that they do not progress onward. And that's it for me.
Well, thank you, Dr. Moxey, for that very eye-opening and somewhat scary and disconcerting presentation, because essentially what you've highlighted is how common non-alcoholic fatty liver disease is, and that it seems to be increasing in incidence. Do you, by any chance, have any ideas on our local incidence or prevalence or changes?
I actually do not. I don't think that we have not really done, there's a lot of things that, no, we don't. The long and short answer is no, we have not really done any studies. To my knowledge, there's no data. I think that this is actually an excellent, research topic for some of our residents, within our DM programs, and to look at it. We know that we've had a lot of conversations about obesity and the incidences of obesity, and we know that we have a lot of incidents of childhood obesity as well. In the Bahamas. And so I think that it would be good for us. We've not done a good job in terms of gathering that research, but I think that that would be an excellent, thing for us to pursue.
And Dr. Bassett says, thank you for including the pediatric NASH. And she was also going to ask that question about incidence. And so one of the things you highlighted was this all starts with steatosis. And you talked a little bit about the transaminases, that they would be elevated. Do you want to just highlight that just a little bit more? Is it the 3 times the upper limit in normal we've been taught, or is it any elevation?
It's any elevation, and it's not, you may not see the elevation of the transaminases with steatosis, with just the presence of fat. Oftentimes, you may get an imaging test that you ordered for something else, and they comment on the presence of there's fatty liver, put on their chemistry serologies, the liver enzymes are normal, and so that's expected. You're not gonna see elevated liver enzymes there. In the presence of fatty liver, and when you're seeing elevated liver enzymes, that's a telltale that maybe they've progressed on to NASH, which is the steatohepatitis. So now and this is the same thing that we even track in patients that have autoimmune hepatitis and viral hepatitis, like chronic hep B and chronic hep C. Sometimes patients can have chronic hepatitis B or hepatitis C or autoimmune hepatitis or even hemochromatosis, and they do not have elevated liver enzymes. And so when you see that, that tells you that the liver is a little irritated. This is how I explain it to the patients. Your liver is inflamed, it's irritated. And so now we're seeing the manifestation of these enzymes spilling into the bloodstream. It's really analogous to when somebody is having an acute coronary syndrome and the heart gets irritated because there's a blockage and you spill those cardiac enzymes into the bloodstream. And so we want to, so it's any elevation. So if I'm seeing even an AST, ALT, and so that's the AST, ALT that I'm speaking of. If they're at 60 or 50 and you have that's minimal elevations, because the upper limit of normal for AST and ALT is around 40 to 45, depending on your labs. That's the upper limit of normal. So if you see these numbers even in the 60 to 70, that tells you that there's some irritation going on, unless there's another reason that you can identify for that elevated transaminases.
Okay, thank you. And Dr. Mandy Pettigan says, excellent presentation. And so while we wait to see if there are any more questions in the chat, I've put up the slide, which you highlighted as some of the things that we can do to reduce the incidence of non-alcoholic fatty liver disease. And so I'm going to ask you a question I'm not sure you can answer, but how can we get these approaches more in our community? How can we encourage people to do these things more?
Well, I think, a big thing is it really starts really within, it has to be a multi-pronged approach. And so I think, it has to start within the home. And in terms of even with diet, it starts even within the schools. So schools have done a good job, from time immemorial in including physical education as a part, as a subject matter. And so we need to encourage that activity that needs to continue. That would have kind of fallen off during COVID, although I know my kids, even though my children were in virtual environment during COVID, with their school, they still had to do physical education. So it was do a video and submit it of them doing these exercises and all that stuff. And so it's important that we really, this is, it's a multi-pronged approach. I think just from the governmental level, there's been, efforts to really thwart against, watching what we put in our bodies. I think there was some effort where taxation was increased in terms of sugary drinks. It's removing, bringing that stuff in terms of the cost of actually having these sugary drinks to make it really cost prohibitive. Watching what's on the menus for the school lunch programs. Taking the opportunity to really encourage, our patients when they come in to, address their weight. Like, oftentimes we're seeing people, we're taking blood pressure and we may take their blood sugar, but are we actually checking their weight during their office visits? Are we tracking that? And so I think it really requires collective responsibility. It's on our part. It's on our elected officials' part to make some of those things cost prohibitive. They are the ones that are policymakers for children in school in terms of, lunch programs. And so just, really getting that message out. I know Dr. Chin has been very taken a special interest in obesity medicine, and she's done a lot of advocacy work. And so, us just really taking that challenge and picking up that baton and really running along with her, in that journey, I think will go a long way.
Well, thank you, Dr. Moxey. I see Dr. LaVille has a question. Dr. LaVille, go ahead, ask your question.
Good morning, everyone. Thank you so much, Dr. Moxey, for an excellent presentation. I wanted to find out whether if you have a young patient with a young adult with fatty liver disease on ultrasound, normal liver function tests, after lifestyle changes, the follow-up ultrasound 6 months to a year later is normal. How often do you monitor this patient, and how do you monitor them? Do you repeat the abdominal ultrasounds annually, or do you do the liver function test annually? What if it's resolved and nothing comes back? Can you discharge that patient?
So if the patient has shown regression, and you're satisfied that that has happened on imaging, as well as their liver enzymes are normalized, there would be no need to continue doing ultrasounds into perpetuity. You may want to say, okay, we have one now at baseline. Let's just check it again in a year and make sure that you're still where you need to be. And I think if that is the case, unless something changes, like you're noticing that they're putting back on more weight, so they've kind of hit that mark where they are, they're developing some of the other comorbid conditions that we know predispose, like, they have the metabolic syndrome. They are showing evidence of insulin resistance or uncontrolled diabetes, or you're seeing a resurgence of transaminases. In the absence of those things, I don't think that it's something that you need to survey on a yearly basis.
Thank you so much.
Well, Dr. Moxey, thank you very much for joining us this morning, and thank you for your presentation. And thank you for highlighting, a concern with the liver that we may not necessarily be thinking about, but that is increasing in our population, given our obesity and increasing diabetes. That could be, a long-term problem that we really need to try and address much earlier on. So thank you for highlighting that for us. And thank you for joining us today. And thank you to you, our audience, for joining us. Remember, our presentations are available on the university website, and it is also available via a YouTube link. So if you're interested in having the link, you can just let me know. And we will see you again next week, Friday, on the 24th of June. The topic to be determined, and so look out for that notice. Take care, and everyone have a lovely day.